or Monday, when you get in. But what we wanted to do today is talk about your review. It's the quality measures and quality improvement initiatives in osteoporosis, and it's an update that you provided. I understand that it touches on pay for performance and requirements by the CMS, Centers for Medicare and Medicaid. So would you mind summarizing your review?
Yeah, sure. So I think, I kind of break it up into three parts. So first, we wanted to take a look at the current performance on several quality measures around osteoporosis care, really centered in the US and using the CMS data that's provided through the HEDIS data set. We then wanted to look at real world examples, so looking at population-based studies, most of which are from claims data, on how people are performing in these areas as well. And I should mention that kind of the three areas of focus around osteoporosis care are: one, screening in women who are 65 and older, so the high risk group who are postmenopausal, using a bone density scan; providing osteoporosis management in patients who have had sustained a fragility fracture. And they choose to focus on women, again, in this area for a quality measure. And that entails getting a timely bone density test, as well as whether or not someone receives a new prescription for an osteoporosis medication. And then thirdly, looking at fall risk assessment and documenting a plan of care for people who have had a risk of fall or a history of falls. And then lastly, our review goes into some of literature review, looking at quality improvement projects that have looked at how different interventions can improve upon these quality measures.
Mm-hmm. And they are a requirement of a CMS, is it not? Are doctors now charged with somehow reporting these?
Yeah, and the important thing to know is that, for example, through the MIPS program, you are allowed to choose what you would like to report on. So you choose 6 quality measures. So I think that it's important to consider when you're looking at, the rates of success, is that, the practices that choose to report on a measure probably already have structure in place to tackle that issue. So it may be that you see higher performance in that area compared to if you were looking at, other systems or the kind of real world scenario.
Mm-hmm. And let's review your findings, the details there that you think would be helpful to our audience who are primarily healthcare providers. I'm looking at the abstract now.
Well, I think,
Mm-hmm.
kind of looking first at, our current performance, I think we're actually doing pretty well in the area of osteoporosis screening. So I think if you look at the trends over the last decade, there's been an increase, a greater than 10% increase in the rates of bone density testing. So women are receiving DEXA screens. There's still, some performance gaps, and in particular, patients that are less likely to engage in primary care, are missing out on that screening. But the estimated rate of screening is about 70%, at least through the CMS programs.
Mm-hmm.
And then I think the area where there's really missed opportunity is actually in the osteoporosis management following a fragility fracture. So this is like, the prime time where you would be able to capture someone who is at extremely high risk of a second fracture. And yet, only, I think it was 40% of patients who sustain a fracture are receiving either a bone density test or osteoporosis medication within 6 months of their fracture.
Mm-hmm. And
Um,
that's phenomenally low, is it not?
it is, and if you look further into, population-based studies, the rates of osteoporosis medication prescriptions
Mhm,
are markedly low, anywhere from 15 to 20%
mhm,
in patients who have sustained a fragility fracture.
mhm.
And so there could be many, reasons that there may not be uptake of medication, but it's still surprisingly low.
Right. So, what reasons are there? Or why is it so low? Why is it the patient, or is it the doctor who's not prescribing or medications or evaluating patients? I mean, where's the
Where's the
problem? Yeah.
Yeah, I think it's a particularly vulnerable care episode. Someone has been hospitalized for their fracture. And then, the assumption is that they're going to see their primary care physician and follow up, and that they will assume that responsibility unless there's direct, implicit direct communication with the primary care doctor that, hey, this patient needs specific focus and attention regarding osteoporosis management. That may actually, kind of fall to the side. And oftentimes patients may be discharged to a skilled nursing facility. There may be a delay in having follow-up care. So I think this this is just an example of where there can be fragmentation of care after a hospitalization. And when we look at potential interventions that can be done, um, for example, when we looked at studies looking at quality improvement programs, I think the most effective tool that has been documented is having a coordinator, a fracture liaison service that can actually meet with a patient during their hospitalization and schedule a bone density test for them. And if they are an advanced practitioner or a physician, they can even, put in that initial prescription for osteoporosis medication so that it doesn't rely on follow-up in terms of initiating this care.
Mhm. And how common is it to have these coordinators? Is that something that is relatively new?
So, I mean, I don't think it's a new idea. However, as you can imagine, it is a upfront, a big investment for the healthcare system. I think one of the best examples that we found is the American Orthopedic Association had implemented a program across several hospitals where they studied the use of a fracture liaison service to try and improve osteoporosis care. They definitely showed an increase in rates of getting bone density tests and osteoporosis medication in patients after their fracture.
Yeah. So, is there funding available to health systems to start programs like this, maybe through the CMS or?
Yeah,
Uh,
it's a great question, of which I actually am not sure. But yeah, you can imagine having dedicated personnel, whether that's a case manager, a nurse practitioner, or for example, some models use like a consultant, like an endocrinology consultant who can evaluate the patient and see if they're appropriate for medication.
mhm,
That's a huge upfront cost,
mhm,
but at least in the few studies that have been done looking at the cost associated or the value associated with these programs, in the end it ends up being a cost savings.
mhm,
um, but
mhm.
you have to, right, have a source of funding to initiate that intervention.
Right, and that's a key problem. Yeah.
Yeah, yeah,
I've interviewed many osteoporosis experts, rheumatologists, endocrinologists over the last few months, and they've spoken about this as a crisis. Uh,
yeah.
they've spoken loudly about the problem itself, but no one has ever zeroed in on a possible solution or a
Mhm,
reason why there is a crisis in terms of
mhm,
when someone has a fracture, there is no follow up, and there's a second fracture
mhm,
of that patient. But here you've identified a gap, which is that patient education, patient,
Mhm.
informing the patient at that stage and grabbing them before it becomes a problem. Just getting,
Mhm.
I mean, getting involved
Mhm.
with them somehow through a coordinator or otherwise. And it seems like such a simple solution. We've also written about the medication gap, how they're not taking their medications or they're not being prescribed. Is that correct? I know the numbers are very low.
Yeah, and it's interesting. Early 2000s, there's a documented trend in terms of reduction of the osteoporosis medication
Yeah.
prescription and uptake. And when you look at, the number of refills that patients are taking, you see that even if it's prescribed, not many people are adhering. And I think there is a lot of fear around rare side effects that
Mhm.
likely contributes to that
Yeah.
in terms of osteoporosis.
Are those real fears, or is there
Well,
any?
I think they're valid fears, but I think if you weigh the risks and benefits, I think at the doses that are typically used, I mean, it's much higher risk for them to experience a second fracture than for them to experience a rare side effect such as osteonecrosis of the jaw, which is often a feared complication from the patient perspective when they're reading about these medications.
Right, and it is a rare side.
Hmm.
I've read that some patients, even physicians, are under the impression it's much more common than it actually is.
Yeah,
Yeah,
exactly.
so it seems like a tough area all the way around, but we're making some progress over the years. And is there anything else, any other final key points you'd like to share with us? Um,
Yeah, I mean, I think um, one other thing that we highlighted in our review is that I think with any system that is going to be investing and tracking these quality measures, I think there should be structural support in order to allow providers and healthcare systems to easily extract this data. I mean, it is a big investment. So as much as possible, I think thinking about innovative ways of using the electronic medical record and um, extracting data from that
mhm,
can be really beneficial moving forward. I think there's an example of in terms of looking at fall risk assessment. Falls are significantly underreported in the elderly population. And so if you were just relying on an episode of care where there's a fall documented, you may completely miss a whole aspect of the population who is at fall risk, but they're not being captured in our medical system unless you were to go into the note and into unstructured data and find that, oh yes, that the provider did have a conversation with the patient about their fall risk. So I
mhm,
think moving forward into the future, I think there's going to be more investment into using that unstructured data and investing in natural language processing to be able to capture that for important quality measures.
mhm. Okay. Well, thank you. Thank you for your
Yeah,
time today.
of
Um,
course.
this has been interesting. I always love talking with a expert who can expand upon our knowledge in this area.